So I'm Mark Luciano. I'm a neurosurgeon from the Baltimore area, and I am at heart a pediatric neurosurgeon, trained as a pediatric neurosurgeon, and see many adults now and see adults for CSF disorders, including Chiari malformation, one of my areas of interest, and including adults mostly now and kids. So I've had the opportunity to see children, infants, young adults, and the elderly. And in our new Center for CSF Disorders, concentrating on the variety of CSF disorders, we see things like hydrocephalus occurring at all ages, and there's many different reasons for hydrocephalus acquired during middle life. There's NPH for the elderly, and of course congenital hydrocephalus for the children. So we know that hydrocephalus is a lifespan disorder. It occurs at any time in life. And with more and more treatment of children, successful treatment, I'm really happy to say that many children are growing up, adolescence, early adulthood, and late adulthood with hydrocephalus. So we're seeing it as a chronic disorder. As I saw that through the years, I realized that we needed to be able to treat adult hydrocephalus better than we have in the past. And that's why we've come to concentrate more on the adult hydrocephalus as well, because they do have a different set of issues, both the congenital kids who've grown up and the people who get hydrocephalus later in life. So the good news, the success, hydrocephalus patients are surviving, as I said, and that's, hydrocephalus is an acutely fatal disease in many instances, and we've turned that into a chronic problem. Sometimes at night I'll be, it doesn't happen too often, but 2 a.m. at night I'm thinking there's tens of thousands of people out there at that moment draining CSF, cc's of CSF out their shunt and depending on it. And the more people that we're shunting, they're all still out there and they all depend on their shunts. And I'm thinking, if I'm thinking about that, I know every patient out there who has a shunt and depends on it thinks about it just about every day. So then now I know I'm going to pull out a tape of music and just relax and go back to sleep if I can. So growing up with hydrocephalus, well, it's a large part of pediatric neurosurgery still. It's a part of every neurosurgeon's general neurosurgery practice. And neurologists say it's a ubiquitous problem. And there's estimated, I think it's more now, but about 70,000 operations for hydrocephalus per year. Billions and billions spent on the medical cost of just the surgery and that acute hospitalizations alone. And what that means for the individual patients, of course, is a burden. There are neurological deficits that are residual in many cases. There's often chronic headache and pain, some of it related to pressure and some of it chronic pain that's taken on a life of its own. And it's important that there's always that constant threat of a crisis. And that crisis can be anything from just severe symptoms to actually a crisis which threatens their lives. So this is always on their mind. And a typical person growing up with hydrocephalus can have something like 14 operations. If you have 2 or 3, you're pretty lucky. 14 is 10 to 14 would be something that's not unusual. I've personally treated patients who have had 50, over 100, and over 200 operations for their hydrocephalus over decades. So it is something that maybe a small number of patients have that kind of problem, but they use up a lot of our clinical concern and energy just to keep them going. So what are the problems with hydrocephalus? Well, as you may know, hydrocephalus is buildup in fluid in the head, and we most simply put, we put a tube in it, drain it in hopefully a regulated way, and it drains into various places, but most often into the area around the intestines, the peritoneal cavity. Well, it's not really a physiological drainage, and the control of that drainage is a major problem. But there are technical problems, like the catheter can break, the catheter can get kinked, the catheter can block or get clogged, and the catheter can get infected. But even if all those things are going okay for a patient, we still in the long term can have problems with shunting in the long term because again, we aren't really shunting the way, well, nature's way of really getting rid of the fluid and absorbing it. We're often draining too little or too much, and that builds up over a long period of time. I would say that over drainage is one of the biggest problems. I put 90% here, but I realize that's an emotional guess. That means that 90% of my thinking and problems surround those patients that have a lot of problems that way. We can fix a kink pretty easily. I'm pretty happy if there's a blockage that we can fix the tube real quickly. But fixing somebody who has small ventricles, what we call slit ventricles, ventricles that have been drained over a long period of time, and the brain is swollen, and there's very little room to drain more fluid, that becomes a chronic problem, one we can't fix often with one operation. So as I mentioned, these ventricles are small. The brain is often very full, when you'll see some images in a moment, but it takes up the whole area of the skull and leaves very little room for the fluid. And why is that the case, and how did that come to be? These are people that originally had very big ventricles and brains that were, they would say, well, geez, your brain is smaller or thinner because of the hydrocephalus. So there's a transformation over time. Well, I guess we could look at shunting as a technology like many other technologies. It has opened up the possibility of all these children living and doing well throughout the years, but also it's opened up a whole new set of problems. It's kind of like agriculture has been believed to help feed millions and millions of people. Where would our society be without agriculture? But at the same time, historians are now calling it the greatest scourge that's ever hit us, for disease and crime and all that. So new technology brings some positives and also some new kinds of problems. As a person that treats hydrocephalus and shunts for a few years now, I guess I see metaphors or references to hydrocephalus all over the place. If any of you can pick up off maybe your shelf of 14th century Italian books, Dante's Inferno, it describes Dante going down into the underground and seeing all the pains and sufferings of people as he goes down to different problems, down to the last circle, which is the center of hell. And he, of course, gets a guide from a tour guide. And I looked at that story, and I realized immediately that he was talking about shunting. That's what he was talking about. And I think many people believe that. So we're going to take a little tour down ourselves. It's a physiological journey into a single problem with hydrocephalus. This isn't all the problems, but it's when you have a person shunted for many years and the ventricles keep getting smaller. It's called slit ventricle syndrome. It could be called collapsed ventricles or just overdrainage. But that cluster of problems is very common and gives, as I said, most of the anguish that we have in treating patients, and unfortunately much of the morbidity that comes to our patients. This is just a quick picture of the circles of hell that Dante will take us down. Of course, he labeled them differently than we will in our stages. We're going to talk about slit ventricle syndrome and the stage of sagging, sucking, swelling, collapse. It's all, what do they call them? Not acronyms. Sagging, sucking, swelling, collapse.
Analogy.
No, what's the same sound in the beginning?
Alliteration.
Alliteration. That's why I picked them. Yes. It's not that profound. Okay. So we could start at the top. This is the successful part of acute hydrocephalus. A person has high development of pressure and volume of their ventricles. We put a tube in and we drain the fluid. Pressure goes down, volume goes down a bit, and this is one of the many successes. And let's not talk about the breakages and the infections, but just look at the shunt. In the ventricle, coming down, emptying off into the peritoneal cavity, patient standing up and laying down. And over time, we realize that our drainage is not really dependent on what the body needs, but often what position you're in and what the resistance of the system that you have. And that doesn't really account for what would make your brain happiest. And as a matter of fact, in a person who's shunted, when they stand in the upright position, their pressure may go down to minus 25 centimeters of water. And that's more negative. Now, all of our pressures when we stand up are a little bit negative. There's a little bit of negative pressure when we stand up. Oh, thank you. Wow. But it goes down a great deal in many people who are shunted. Now, some people tolerate that quite well, and you never really know about it. But over time, more and more, we come to know about it because they start to have problems. So it can be all right in the beginning, but over time, there could be a problem. So I guess one of the simplest problems of overdraining that you can imagine is a basketball losing air, getting drained. starting to sag. Or if you're a Patriots fan, maybe a football sagging a little bit, right? Or a balloon. So if you look at that, that often can occur in the beginning stages of slip ventricle syndrome, or it can occur later on. We'll call that stage 1 and sagging. So you can get headaches from overdrainage. We all kind of maybe have heard of that, because when you get a lumbar puncture and get fluid removed acutely, you can have headaches when you're up. They're often positional. But more importantly, when the brain sags, it includes the brainstem, and cranial nerves can get stretched. You can start having double vision. You start having problems swallowing. And there's problems throughout the neural axis that can occur as your brain sags. You can also get subdurals, because there's fluid that takes up the space where your brain is starting to sag. Let's see if we see some pictures. So subdurals and acquired Chiari. So this, I think, is one of the ways that the CSF Disorders interfaces with Chiari quite often in my clinic. Is I get references for or consults for Chiari, and we have to make sure that the Chiari is due to a tight posterior fossa, and not due to what we call an acquired Chiari, or we call here an anomaly, where the brain is being pulled downward by lower pressure. And the whole brainstem here is falling down and crowded and pushing its way into the spinal canal. And there are measurements that we could take to show that when there is some sag, it may be related. It can be called a Chiari, but it may be related to a CSF disorder, that is sagging of the brain. These people can have leaks down below, but they also can be having sagging from a shunt above. Here you see subdurals. The brain is shrunk down a little bit, like that football, and it's got the subdurals over the side. Here you see Chiari. These are patients who have acquired Chiari. The important point about the sagging is that if you treat this like a Chiari malformation, or if you treat this like subdurals, fluid collections, because a neurosurgeon, one of the first neurosurgical operations in history is drilling a hole and draining the fluid. If you do that in this situation, you can end up with more fluid or fluid and blood. And that's because the problem is not that this fluid's pushing down. The problem is that the brain is sagging and the fluid's just taking up the space. Same thing with the Chiari. If you do a Chiari decompression and the person actually has acquired Chiari from low pressure, into what we call intracranial hypotension, CSF leak or CSF overdrainage, they can get worse after the operation. In some patients that have a shunt like this, their Chiari symptoms get worse or get better, depending on your drainage. And it's a very tricky business, because too little drainage may mean the ventricles get bigger and push down more on your Chiari. On the other hand, if you overdrain, you can get some overall sagging, and the brain sags and you get more compression down below. So you really have to hit that sweet spot in between where you're not sagging and you're not pushing. It can be quite a sensitive area when this area is tight. And the real, what's that?
This might be able to advance it since it's still plugged in.
Is it? Is it? Oh, it is. Oh my gosh, that's great. So that's an important area that we look at when we look at patients with shunts and the possibility of overdrainage. I've had patients that we've referred have had 3 Chiari operations, and it was unrecognized that they had overdrainage from a shunt. As a matter of fact, I was guilty of considering the 3rd one. We didn't do it when we found out the shunt was working and that it was way overdraining. So it's something very important to realize when you're looking at Chiari malformation in a person with a shunt. Now, you can have quite bad symptoms in this situation, but as it turns out, the cranium, the rigid skull, is very important to keep your brain from collapsing, from sagging. As a matter of fact, when we're up, as I mentioned, we have negative pressures, and we're protected by our skull from atmospheric pressure pushing down. If you don't have your skull, well, then you can get really, let's see, I push the forward button, yeah. This is a person who has a craniectomy, and their brain just sagged right down and became lethargic and comatose. And there's a shunt in place. It can happen a bit without the shunting, but when you have a shunt in place especially, you have drainage from the fluid, drainage of fluid from the shunt, and you have the whole brain sagged down. This is just an axial, but you can see in the sagittal that the whole brain is herniating downward and so forth. So the skull is very important to keep the brain up. And what it does, I should do this, is get us to the 2nd stage. The 2nd stage is really in part a compensation for that negative pressure, for the negative pressures that you get when you drain too much. That compensation is really, neurosurgeons love this because it's a very simple rule, Monroe-Kelly doctrine. It's as simple as you get because it says that within a rigid skull space, when something is removed, something has to be put in its place. It's like, nature abhors a vacuum, right? So if the CSF is drained out, something has to take its place. What takes its place is usually venous blood. Low pressure venous blood tends to pool and enlarge. What also takes its place is interstitial fluid to some extent as well. So you have more accumulation of blood in the veins and in the interstitial fluid when you have overdrainage. What happens then, you'll see in a moment. I'll show you what we see in X-ray. I'm getting the hang of this. So here's normal. Here's that football that's a little bit collapsed. And here's the subdurals and fluid that's gathering over the top. And this shows you the main vein, the sagittal vein that goes across the top of the skull, is enlarged when there's overdrainage. And other veins throughout the system are also enlarged, but it depicts those. It also shows you in red here the coverings of the brain, which are highly vascular and also get enlarged with venous blood when there is overdrainage. So you have a picture of thickened membranes out here, enlarged veins. The pituitary gland here, compare it here, is also a very vascular organ outside the brain, but in the skull. And so it enlarges as well. So the whole brain is feeling this negative pressure, this sucking. And blood is pouring in from other sources, low pressure areas, in order to try and help or mitigate that negative pressure. When it comes down to X-ray, here you see contrast enhancement shows the very thick membranes all the way around. This is abnormally thick, trying to thicken, enlarge, and filled with blood because of the negative pressure that's in the head. That's a good diagnostic tool, but also it tells us what's going on. It tells us this person is sucking in a lot of extra fluid volume to try and compensate, which with what the neurosurgeons have taken out. Here we just see the diagram of engorged cerebral veins. And this area is a little bit uncertain as to what's happening in the brain. It's actually an area that we're researching in our laboratory about what's happening in the brain with interstitial fluid as these changes occur. But they both end up really doing one thing, and that's increasing the brain volume over time through the engorgement of the cerebral vessels, which also causes some engorgement of fluid within the brain itself. The consequences, well, those big engorged veins can bleed, and we see that often in the sagittal or in the meninges. They also, amazingly, sometimes people come up with extremity weakness. And that's because those engorged veins around the spinal canal actually press and can cause a compression of the spinal cord. It also, as we mentioned and alluded to before, it can cause worsening Chiari, but this is in a different way. This is because of increased venous sizes and worsening headaches, because those inflamed membranes, those enlarged membranes, can be more sensitive, although we're not really sure of the reason. So this has consequences in itself, the sucking and the sagging, because of a variety of changes which occur, but the ability of the veins and other fluids to try and fill in the space is really a response to the initial negative pressure and sagging. So this is the third stage. This is the third ring or circle. This is swelling, and this is pivotal because here so far you had a situation that there's been some drainage perhaps over some years. The ventricles are getting a bit smaller. The patient maybe has occasional headaches. But this is all really reversible at this point. If you were to add some different resistances and different things that we'll talk about in a few minutes, then you could probably change the drainage patterns and not cause over drainage. This is pivotal because at this stage, the passive engorgement that we see of those veins that I showed you becomes an active swelling. The pressures of those veins become higher in the brain, outside and inside the brain tissue. And it turns out that the blood, the fluid in the brain, and the lymphatic flow out of the brain that are in the meninges and around the vessels is disturbed. And there's positive feedback loops that develop that worsen the brain expansion and render it less reversible. And the key is, as we develop this syndrome, sometimes over many months or usually years, that this swelling of the brain in a sense becomes malignant. It can't be stopped or reversed easily. So the ventricles stay small. Quite honestly, they can be opened up in some cases at stages, but it becomes much more resistant to reversal. Positive feedback loop. We have positive feedback loops in nature all the time. when the sun beats down on the glacier, the white glacier, it melts. The water on the surface is darker, so it absorbs that sunlight even more and melts even more, which causes more, and that's a positive feedback loop. And so we see that all the time in nature, and you're going to see that in this situation, when this takes off, it's because that there's a lot of positive feedback loops that cause swelling to occur. The consequences, it's more difficult to diagnose shunt failure. A person can have a problem with the shunting and high pressure, and the neurosurgeon looks in the ED and says, your ventricles are the same size, they're not expanded, they're small, no problem. Well, there is a problem because your ventricles don't expand the way that many people would, and it's not uncommon. We have to check the pressure. We have to do other checks to see if your shunt's working. Also, of course, it makes the treatment more difficult because we're targeting small ventricles. Targeting small ventricles, well, obviously, simply you can miss, but also there's more of a chance that tissue around the catheter will block the catheter. And also it leads to the next stages of problems with this disorder. So we have those engorged veins, we have the increase in brain fluid volume, all increasing the impregnable volume, we have the swelling, and we're adding here the smaller non-expanding ventricles, okay? This causes, the reason we think that this happens is that the venous drainage as the brain grows, which is on the outside of the brain, tends to get constricted. The sinuses or the veins, the bridging veins on the surface of the brain, as the brain expands, it starts to block off its own exits. That's true for the venous blood. It's also true for the lymphatic vessels. So the brain is expanding. It's been pretty passive, but as soon as it gets to a point where it's blocking off the exit of those fluids from the brain, it starts to expand even more and more. I don't know if any of you have, I hope not, gotten your thumb caught in a bottle, and as it sits there, it's starting to swell. Well, as it swells, it's even harder to get your thumb out, and it's getting more and more blocked. Another positive feedback loop. Same thing happens in the brain. As the brain grows, it blocks off the outflow and grows even more. So, venous hypertension, that's the veins in the brain. Decreased flow of lymphatic absorption. You have smaller, less reversible brain expansion, as I mentioned before, and even more shunt failures and worse symptoms. So this is the next stage, swelling. And this is, again, the less reversible part of the procedure, of the process, I should say. So this shows the veins, and now you all don't know normal, I should have put a normal up, but there's transverse sinuses that usually go this way that are already pinched down and blocked. There's a lot of bridging veins and other veins here that should be visualized that are not. This person has a disturbed venous return system, and this is a person with slip ventricle syndrome and a swollen brain. In a similar fashion, and this is actually brand new science in that we're finding lymphatic vessels all along the venous channels as well, and they're highlighted here, I think, in greenish and here in red. Along the venous channels, the lymphatic exit of fluid from the brain is now better described as it comes out of arteries that were in the brain, and also goes into the meningeal, the coverings of the brain. And these vessels are also vulnerable to blockade with that growing brain. So here you see as the brain grows, you're blocking off veins, you're blocking off the lymphatic outflow. And that, just like elephantitis, or just other areas where in the body you have swelling because of lymphatic blockages, in a sense you have it here in the brain as well. The next stage of slip ventricle syndrome is collapse. Well, the ventricles are getting bigger, you're imagining this. And even when they're not so big, you can see the trend here where you can suck here, the ventricle, the foramen here blocks off because that membrane's pulled over, and now all of a sudden this is trapped. And the other side isn't drained as well. So you start to get asymmetries because certain areas collapse, certain foramen that connect all the ventricles, there's 4 ventricles in the brain, they're all connected but can be blocked. Well, that starts to progress. So you start to have situations where the brain, which is not hard but a soft jelly-like substance, can be changed in its shape and start blocking off the connections between the ventricles. Here's an example. Very tough person to regulate properly. She has a tectal mass here that blocks the flow of CSF. Has hydrocephalus. You see bigger ventricles here laterally, bigger third ventricle. These are the temporal horns, all big. Put a shunt in, and we can be quite pleased at first because, well, the ventricles are nice and small. You may notice from the pictures that the catheter comes in from the right side, and it really does and in an area where there's not much tissue. Everything's collapsed around it. And the ventricle actually ends up being small. Here you see here, the ventricle stays small and collapsed, where the other one appears to be trapped and starting to get bigger again. This person ended up being very hard to regulate. Their ventricles would blow up very quickly sometimes or stay closed. And so here you have ventricular trapping, or a slit ventricle syndrome on one side, and hard to regulate. Here you can imagine the feeling of a neurosurgeon when he looks at this, because we put that catheter in. There's the tip of the catheter. If you look at other levels, you can see it going down to this point. Here you see the ventricles. It looks like you stuck it right in the brain. We didn't. There was ventricle there. And now it looks like it's, people look and say, well, I know your problem, it's in the brain. Well, it was in the ventricle. The ventricle's really sucked down and gone. And so how well is that catheter going to work tomorrow and next week and next year? It's amazing that they do work. If you do a shunt patency study, you'll see that they're still often draining fluid, sometimes right, you think, from the brain itself as opposed to the ventricle. But it's in danger of stopping because the ventricles collapsed around it and stops it, or it's in danger of blocking because tissue that's in the ventricle can grow into it. So we're worried about this kind of situation, and we should be, because it is a tenuous situation that some people do well with for years and others don't. So the collapse is due, of course, to what we've been talking about, the expansion of the brain and the loss of fluid, and it results in isolation of the ventricles. And this is important. You're draining on the inside of the brain. There's fluid that goes around and flows on the outside of the brain as well. That area is not being drained so well because as the brain collapses and the ventricles collapse, you're draining more on the inside, and you often lose that connection with the outside. So that becomes a problem. And as I mentioned before, you can have episodic blockages or permanent blockages based on that collapse. A lot of times we try to figure out, is the shunt really blocked? Did tissue grow in? Or is the shunt just fine? It's just drained so much there's a collapse. When there's a collapse, you can imagine the catheter sitting there and tissue all around it. And it takes a certain amount of pressure to then open the ventricles a little bit, let fluid in, and then the fluid flows and it collapses again. It's sort of like an oscillating up and down. And you have episodic headaches. Pressure builds up, 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 and then it releases. So that's a classic episodic headache of slit ventricle syndrome. That's different than when a shunt is really blocked, and then you just have pressures that are really high. But you should remember that even if you have a blocked shunt and pressures are high, those ventricles may still stay small. So if we go back to our diagrams, we see the engorged vessels, the increased volume, and the stages of sucking, of swelling. We're adding to that collapse. And as I mentioned, an important feature of the collapse is when they collapse, you have decreased drainage of the CSF drainage. The CSF pressure around the brain goes up. And that means that the more fluid gets pushed into the brain from the outside. And that's part of new discoveries that are made about the flow of fluid in the subarachnoid space, the area around the brain, and going into the brain. And we know now that there is fluid, ample fluid, that's going in from that direction. And with higher pressure, undrained, out here, you now have fluid being pushed even more. That same fluid, I didn't draw the line because we're going to make it messy, but that same higher pressure in the subarachnoid space squeezes down on those veins which are in that same space, and also helps increase the blockages of the veins on the outside. So the lack of drainage of fluid on the outside now is causing problems both with fluid in the tissue of the brain and also problem with that blockage of the vein efflux of blood. So again, these are all loops. You can see when you have tissue volume increase, increased stenosis, increased vein pressure, engorgement, which increases the tissue volume. That's a loop. These are all loops that occur. I won't go through them all, but this explains why when you hit level 3, that expansion, that blockage of veins, it starts to get worse and worse and out of control. And so you're probably saying at this point, well, why don't you just stop it in the first place? I really wish we could. But many of these patients are patients that were shunted 10 years ago, 20 years ago. And the process of going on, the fact is, when we see our adult patients in the clinic, they're already at different stages along this route. And some of them are stages that have become very difficult to deal with. All right. We've gone through sucking, swelling, collapse. Well, the last stage we're going to talk about is just simply, well, I won't call it end stage, but there's very, very little ventricular space at all. And The catheters are surrounded by tissue. We get what we call refractory shunt failures, and you have episodic and sustained failures of shunting. And you wonder, if that shunt goes wrong and I got to put it someplace else, where would I put it? And it turns out it becomes a very difficult problem. Frequent shunting, collapse-based blockages, high risk for tissue ingrowth into the shunt blockage because it's surrounded by tissue, and multiple shunt operations. That's stage 5. And we see many patients come in and they've already been through this and had many operations, and they're in stage 5 chronic shunt failure. What are we going to do? I haven't talked much about treatment. There are things that we can do with slip ventricle syndrome. Obviously, drain less makes a lot of sense at this point. There are multiple approaches, but it does depend on the stage and the specific cause. And it's usually based on less drainage and connecting those fluid spaces, getting rid of the trapping. All right? The problem is, a lot of times this took years to evolve, and it's not like you could just change it. The patient always wants it changed in, I would too. Let's get rid of my headaches and let's do it in one operation and more quickly. And it's difficult. I've heard many times the mother of maybe a 25-year-old saying, he's had that shunt for 20 years, he's been fine. And now he's having all these problems. Put the same shunt he had 25 years ago, and that would work. Well, that shunt that was put in 25 years ago has over time overdrained just enough to get us into this situation. And now it's a different situation. We certainly can't put the same one in, and we can't treat it that way. Prevention of slip ventricles would be a much better idea than waiting to deal with it when it develops. And this is our message. The message of the adult neurosurgeons, or the pediatric ones that are treating adults, is to go back to pediatric neurosurgery and say, please, let's right from the beginning start draining less and start finding out how we can control CSF drainage from the beginning and through adolescence and try and prevent this from happening. So, the treatments. Ironically, if this is all due to too much drainage, there is still many operations done for draining more CSF. Well, if the catheter is blocked, here's a catheter. You see the tissue in it? Well, tissue grows in. Usually it's the lining of the ventricles, the ependema. Could be choroid plexus, which makes the CSF itself. It grows into the little holes and blocks it. Well, these people need shunting. So if they're not getting any, and their pressures are always high, which you could determine with ICP monitoring often, they'll need to be repaired in order to get them to drain more. So you have to unblock the shunt in that situation. Other situations, they'll be in a ventricle, like you saw before. Oops, I'll go back to it. Which is collapsed. Well, here you see what they did is they said, oh, you're collapsed here, but they had a fluid space here, so they put another catheter in here and drained it and figured that'd be okay. That was okay probably, well, in my experience, 6 months, maybe 12 months, until that area collapsed. And then, I think you can see a hint of it, there's more of it here. Then they saw big areas in the back that still had fluid. They put a catheter in. This patient has 3 catheters in the brain. Each one of them, you see it here too, it collapsed. So when you try and find other little areas that you can drain more, where you still see some fluid, it's really, shall we say, kicking the can down the road, because it'll help for a little while, but the brain is still jelly, and if you drain over a period of time, it will often collapse. So, and this is an old paper, and they show that they tried this, and you see the ventricles are actually much bigger here, and that's because they ended up doing an operation where they increased the resistance of the valve. It didn't affect the ventricle size up here very much. It did a little bit back here, but the patient felt much better. And their suggestion was, hey, don't put in all these catheters right from the beginning. Start adding resistance to your valve. Makes a lot of sense. In the meantime, we have adjustable valves. We don't have to do surgeries. We can go from having very small ventricles. Here, this patient has encephalomalacia in the back. But you see in front, there's slit ventricles here, bigger ventricles, and you can really dial the size ventricles that you may want. And often it's a little bit larger than we think. Our goal in shunting is not always to make the smallest ventricles. It's to make the ones where the patient is doing the best, basically, and has least symptoms. So it's not always, they don't always expand, because as I said, it can't be irreversible. And it's not always tolerated. Sometimes those pressure increases that you have to do as you go up cause too much patient suffering, and they can't go up. Because you're trying to do it slowly, but also do it expeditiously to try and help their drainage. So this is the strategy, and this seems to work. We're currently reviewing all the patients, and my team says it helps, something like 60-70% of the time that adjustments can work, even at this stage when the ventricles are slit and even when they're adults. So would it have been better to do it early? Would it be better to adjust and do less drainage at an earlier age? Yes. Another way to treat slip ventricle syndrome is drain better. And by that I mean you can even out positional drainage with anti-siphon devices. And I won't go over them because we don't have time, but there's many devices. They work differently in different situations, have different positive and negative features, but basically they're all trying to regulate the flood or the waterfall of fluid that goes down your shunt when you stand up. When you stand up, there's more fluid that comes down just because of gravity. And it tries to inhibit those, so they're most often they're in some ways position dependent or gravity dependent. We can also drain better by communicating the areas. We don't want a shunt to get trapped in one ventricle and have a big ventricle right next to it. So sometimes we open up a septum in between them to try and communicate them. If a patient has obstructive hydrocephalus, we can do what's called a third ventriculostomy if we can expand the ventricles enough and communicate the inside of the brain to the outside of the brain, the subarachnoid space, which I mentioned is very important for the development of slit ventricle syndrome, that stage 4 we talked about, the collapse. So endoscopic procedures, including endoscopic third ventriculostomy, are very important in many cases where there is lack of communication between areas to try and communicate if possible. Now, another important way to try and treat, if there is communication, and only if there's communication, is to do a lumboperitoneal shunt. And I think you can see here, a catheter comes around and then goes into, here it's coming around this way and going into the belly. And here it's going into the spinal canal. Here it is in the belly. A lumboperitoneal shunt drains fluid from the outside of the brain and not inside the brain. And that can be helpful because it's not collapsing any brain. You're getting rid of that high pressure in the fluid around. Remember we said there was high pressure around the brain, a fluid that was pushing more fluid into the brain and expanding it. So that helps that as well. So it turns out that lumbar shunting, which has its own set of problems that we don't have time to get in today, but it can be very useful in the treatment of slit ventricle syndrome. Sometimes you can't do it because there's obstructions above and you can't drain from below the fluid above. And here a paper from Burkett in 2006, he actually went and did what's really Chiari decompression procedure. He did a posterior fossa craniectomy, put a bar across a cranioplasty, and put a shunt in the fluid space that's here. Trying to drain from here, outside the brain, as well as from the inside of the brain. So you can see there's a lot of procedures which have been developed to try and drain better in situations where it's difficult, and to try and drain better outside the brain. Finally, when you find no spaces that you can drain to, and especially in situations where a child has been shunted for hydrocephalus before the age of 1. If you're shunted for hydrocephalus before the age of 1, your skull itself may have slightly, well, it may have stopped growing a little bit because it actually is the pressure of the brain which causes growth of the skull. Their skulls can be, and sometimes you can't even perceive this, but too small for the head inside. And in those cases especially, a craniectomy, in other words, enlarging the cranial vault, may be your best option. We can call it last resort, but in some situations it ends up being the only resort that really works, and it can work. Here you see one of the procedures. This is, I think, is a very neat way to do it, and we've done it this way. I've done it many ways historically. But here you have relatively large panels of bone that you're taking out on both sides. You're taking those panels of bone and you're cutting the inner table away. That adds about 3-4 millimeters of space. If you add 3-4 millimeters of space all around your skull, and the places between those panels, you're also thinning and drilling out. So you've increased the whole skull from the inside by about 3 or 4 millimeters. That sort of expansion can help. So I'm going to end by going through a kind of index case that takes us through all the levels, all the circles. This patient, well, when I saw her films, my heart kind of sank because you can look at this. There's a knot of plastic right in the middle of her brain, silicone, and these are flanged catheters that are almost impossible to remove without hurting her. She has 1, 2, 3, 4, 5, 6 catheters. We can see she has a total of 8 catheters in her head from all around, from people trying to desperately find ways of draining her over time. She has catheters that are bilateral and a very complex system. And when I saw that picture, I just said, I hope I don't have to try and revise this. Because you'll also notice there's not a whole lot of fluid space left to put a catheter in. So what do? She presented with over 250 operations. 8 catheters in her brain, flange catheters, hard, risky to remove, and presents with, she unfortunately did, she presented with a chronic infection, not surprising after 250 operations, and an infected cyst in her belly. Well, we removed the infected cyst, we put in new catheters distally. I did not try and revise any of this. We also fixed her scalp, which was eroding. She is a wonderful, beautiful, relatively high-functioning person who I'm delighted that she is doing as well as she has been after 250 operations, but I still look at this and wonder what's going to happen when her scalp erodes again, or when the catheters that are there block up, or the infection rears its head. She's on chronic antibiotics. So this is a bit of an extreme, but it's not uncommon in terms of what's happened to her. Multiple repairs, targeted shunt fluid spaces, flange catheters, adjustable anti-siphoning devices, attempted fenestrations, and you don't see it here, but she's had temporal craniectomies, and she's had a posterior fossa release. She's had almost everything over this period of time to try and treat slip ventricle syndrome. Wonderfully, she's doing well, but she's been through, well, hell. And she's doing well now, and I'm worried about the future. She's in her late 20s. Well, yeah, so what did we find? What did Dante find in the center of the inner circle? He found Satan, and Satan, when I saw this, it really reminded me of this picture. Because I looked at that, and that's a monster right there deep in her brain, and there's the Satan. So conclusions, I won't read them through, but you can see that this is a complex and evolving process with multiple treatments, and we have to be sensitive to where we are in that procedure and in trying to reverse it. Better not to get into that situation, but that's a reality we don't have right now with all the people in the world that have the shunts. Thank you very much.
Thank you.